Regular listeners to Quick Takes may remember an episode on the association between antidepressants and increased risk of vertebral and hip fractures. I do, as the increased risk is concerning, but the magnitude of the absolute risk is unclear. The quandary is due to a possible confound by indication in studies included in that meta-analysis, in which a substantial portion of the increased risk could be due to the indication, major depression, as well as the antidepressant medication. But in this episode of Quick Takes, I am happy to say we have a whole different situation to consider. A different medication, lithium, with an improved study design that only includes subjects with bipolar disorder to assess changes in bone mineral density. Hi, Paul Zarkowski here with the Psychopharmacology Institute. The authors recruited 117 women aged 20 years or older with a diagnosis of bipolar disorder 1, 2, or not otherwise specified. Aerial bone mineral density was measured at the posterior anterior spine, total hip, and total body. 35 of those 117 women were currently taking lithium with a median duration of use of 64 months. One improvement in this study is that all subjects had a diagnosis of bipolar disorder, with the only difference in the groups being the current use of lithium. Using an unadjusted model, the women taking lithium had a significantly greater bone mineral density in the spine, and a trend towards greater density in the hip and total body. After adjusting for age and weight, bone mineral density was significantly greater in both the hip and the spine. The authors also included other factors in their model, specifically smoking status, rating of physical activity, alcohol and calcium intake, socioeconomic status, past lithium use, and other psychotropic medication use. None of these other additional factors were significant or improved the model, but adding bone-active medications improved the model and included both those that improve bone health, specifically anti-resorptives, hormone therapy, calcium and vitamin D supplements, or those with a negative effect, oral glucocorticoids, and thyroid hormones. Controlling for the prescription of bone-active medications, along with weight and age, improved the final model, in which lithium users had a statistically significant 5.1% increase in bone mineral density of the spine and a 4.2% increase at the total hip. Total body mineral density was 2.2% greater in lithium users, but was not statistically significant. Low bone mass was defined as a bone mineral density T-score of less than negative 1.0 at the spine or hip. Lithium users were also significantly less likely to have low bone mass, with 43.9% of non-users having low bone mass, but only 22.9% of lithium users. The authors point out that the groups did not differ significantly in any characteristic, including age, weight, height, alcohol or calcium intake, smoking status, or activity measures, with the exception of bone mineral density and socioeconomic status, with lithium users overrepresented in the middle two quartiles, but underrepresented in the lowest and highest quartile. To conclude, this study supports a positive effect of lithium on bone mineral density compared to other treatment options for patients with bipolar disorder. But you may still be wondering if the net effect is positive compared to healthy controls. For this, the authors cite another study that shows that patients with bipolar disorder on lithium have a lower incidence of osteoporosis than those without bipolar disorder. The authors discuss a variety of mechanisms for lithium's positive effect on bone mineral density, including increased activation of osteoblasts through activation of WNT beta-catenin via inhibition of GSK3. In contrast, the mechanism of the negative effect of SSRIs on bone mineral density is suggested by an in vitro study in which serotonin at low concentrations inhibited osteoblast proliferation, differentiation, and mineralization. All of the medications included in the meta-analysis on antidepressants and bone health had serotonergic activity, including SSRIs, TCAs, and SNRIs, but with the notable exception of bupropion. The study in rats showed an osteoprotective action of bupropion through suppressing osteoclastogenesis-inducing factors and inflammation, which stabilized the osteoclasts and decreased bone matrix degradation and resorption. Maybe the quandary on the effect of antidepressants on bone health could be resolved by following the methodology of this study on lithium, by comparing bone mineral density of patients with major depression taking only SSRIs to patients with major depression taking only bupropion. In conclusion, this study provides evidence for lithium's positive effect on bone mineral density in patients with bipolar disorder. This effect could be added to lithium's relatively unique positive effect on incidence of suicide. Both effects can be considered as the benefits of lithium to be balanced against the risks to renal and thyroid function for each patient.